family, good morning, good afternoon, good evening, whichever time you are watching this video from. Welcome to my YouTube channel. My name is Jemienaftaly and this channel is called The Pediatric World. It's a channel on kids' welfare. We try to, it is all about the medical problems that affect children while growing up. So then we want to create the awareness to the mothers, to every caregiver, whoever is taking care of this child, so that they may understand these diseases. So we want to create the awareness and also the know-how on these illnesses that affect these children. So if you haven't subscribed, please be part of this wonderful family. Hit that red button, subscribe. In a minute, just subscribe so that you may be a part of this family. So we are still continuing on our topic on HIV in children, and in our previous episode we started on how the TB and HIV correlate. How, because we say they coexist, it is rare to find one and not find the other. So this is the meaning of saying they coexist. So we started on the pulmonary TB as an opportunistic infection. Now today we are going to do the clinical examination and also the diagnosis, how to say this is really a pulmonary TB. So then, clinical examination, these are the signs that are suggestive of pulmonary TB. So what signs do we see and say this could be pulmonary TB? Last time we did on symptoms. So we said that weight loss, poor weight gain, or low weight for age. This is one of the signs that we could be having pulmonary TB. Also we said fevers, persistent fevers. When we come to the respiratory system, we have increased respiratory rate. So this is the rate at which these children are breathing. They are breathing so fast, they have increased respiratory rate. So this could be a sign of pulmonary TB. We also have increased signs of respiratory distress. Again, difficulties in breathing when it comes to respiratory system. We also on auscultation. Auscultation is when we use, as the professional caregivers, we use the stethoscopes to listen to the chest. This is auscultating. So whenever you auscultate, you find we have abnormal sounds like the ones we call crackles. So in a normal chest, you should not hear any those funny sounds. So the chest should normally be clear. But if you find these crackles whenever you auscultate, this could also point, it could be a sign of pulmonary tuberculosis. There's a note, an NB, normal respiratory findings does not rule out pulmonary TB. In as much as we are saying that they have increased respiratory rate, so if you find normal respiratory findings, don't rule out PTB. We have other signs that we can check for to still say this still could be TB. So if you find a normal respiratory finding, don't say then there's no PTB. This is what this note is all about. Then we have things like a typical clinical presentation of pulmonary TB in children. So we have number one, something we call acute severe pneumonias. So here it is characterized of what? This acute severe pneumonia. They have fast breathing and also chest wall indrawing. So chest wall indrawing, we mentioned it somewhere. This is whereby the child is struggling to breathe and the chest normally draws some lines so that you are able to tell this child is using more extra muscles to breathe because they are not able to breathe normally. So they have fast breathing and also chest wall indrawing. And this occurs especially in infants and HIV infected children. Something else is that suspect pulmonary TB if poor response to antibiotic treatment, and if HIV infected, also suspect other HIV related lung diseases. We are saying that if it's a normal cough, it's a normal normal infection, so it should respond to a good antibiotic, broad spectrum antibiotic. But if this is not happening, if it is not responding, then think of more, which it could be pulmonary TB. So this is what all this means. Now, another atypical clinical presentation is something we call a wheeze. A wheeze, they are those, I know you are familiar with them, especially to the asthmatic patients. So a wheeze is caused by airway compression. So whenever a patient is wheezing, the airway is compressed. They are not able to breathe normally, and this is due to the enlarged tuberculosis HeLa lymphadenopathy. So normally we have lymph nodes that are enlarged in PTB, and these are the ones that are preventing the lungs to dilate normally, hence causing these sounds, this wheeze. So this is another atypical clinical presentation of pulmonary TB. You might miss it because every time people hear of wheeze, they think of asthmatic patients. So it could be TB because of the same reason that we have said. Now, that was about signs suggestive of pulmonary TB. How about diagnosis? How do we diagnose? Clinical assessment in all cases consider, number one, the history of contact with adults with pulmonary TB. So history of contact is very, very important. This will help us to diagnose this pulmonary TB. What do I mean with history of contact? You as clinical, healthcare workers, we should ask on history of contact. We ask the mother, is there anybody in the family that had a severe cough, a bad cough that lasted for more than 2 weeks? Anybody who had TB in that family, in the setup that this child was staying? So this is a history of contact. Why? Because if there was someone with a chronic cough, if someone was even had TB, an adult, they could give this TB to these small kids, because these small children, remember, their immunity is already down. So that is the importance of asking for history of contact with adults with pulmonary TB. The contact may have occurred weeks to months earlier, so you should ask about this. Now, other things to diagnose are tests. We have something we call tuberculin test. Tuberculin test. Every time a BCG is done, normally there's the inodulation that should come out. So this is all about it, because we want to see if it is there. We do the testing. We also have something, a common thing that is going to diagnose pulmonary TB is chest X-ray. You want to send this child for chest X-ray if you suspect pulmonary TB. Or it could be a miliary TB. Miliary TB is TB that is in any other organ apart from the pulmonary, apart from the chest. So this is what we call miliary TB, and they have different clinical manifestations in an X-ray. So that is why a chest X-ray is very, very important. Other ways of diagnosing, we have microbiological diagnosis. We want to do some smears of the gastric aspirates. So we want to take these aspirates for smear testing. We may need to do culture and sensitivity of the sputum. We also have something we call sputum for gene expert. This is the commonly used nowadays. There's also a note, an NB, note that a negative tuberculin test again does not exclude pulmonary TB. So when you find that there is no tuberculin test, when you find it is negative, this is not supposed to tell you that there is no TB. This is not enough. It alone is not enough to exclude pulmonary TB. This is it. This is about. This is what this is all about. I hope we are together, and I hope you are able to understand. Now, going back to the sputum for gene expert, in children it may be difficult to get that sputum for lab investigation. Why? Because mostly these children are going to swallow this sputum. They are not able to expectorate it, so it might be a bit difficult. So, but it is one of it. We have ways of doing this. so that we can be able to get this sputum to go and test. So I hope this is clear, you are able to understand it well. So thank you for staying tuned. This is the end of today's episode. Thank you for staying tuned. If you haven't subscribed, please hit on that subscribe button. Subscribe so that you may be part of us. To put on your notifications so that you may be among the first people to note every time I post a new video here. Thank you so much. Till next time.